Okay, so let's talk a little bit about doing MR imaging for arthritis. If you look at protocols, there's always been a debate about whether to give gadolinium or not, because it does increase the contrast does increase the cost of doing the procedure. Risk is pretty minimal. Now, what's been shown by some studies in Europe is that gadolinium does improve the specificity for synovitis, and it also improves the sensitivity for tenosynovitis. So a lot of limited protocols which have been developed in Europe and places will just do 3 or 4 sequences, one of which is post-contrast to minimize the time it requires. In reality, the cost of MR in respect to the cost of all the rest of the care of people with rheumatoid arthritis is pretty minimal. So the actual cost of MR is not doesn't significantly change the economics of treating these patients. So let's review the critical information that we want to get to treat patients with rheumatoid arthritis. One is we want an earlier diagnosis. Because we want to make the diagnosis and treat these patients while they still have reversible disease. And we want to know whether they have erosive phenotype or not. If it's erosive phenotype, we want to treat more aggressively with more expensive medications than if it's bone erosions are not a major part of their disease process. We want to detect and quantify the amount of synovial inflammation, and then we want to evaluate cartilages and other soft tissues. So if we look at early diagnosis, what a number of studies have shown is that there is a value for MRI and helping differentiate what in the past was called undifferentiated arthritis from rheumatoid arthritis. And I won't go through a lot of these, but there have been a number. And principally right now, what MR can do is detect synovitis and erosive changes much earlier than physical examination or other techniques. And as we'll see in a minute, the new diagnostic criteria are relatively new, not so new anymore, for rheumatoid arthritis. The joint count, the number of joints involved, is a critical component of an early diagnosis. So MR has been shown to allow the diagnosis and fitting the criteria for rheumatoid arthritis earlier, and that it's more sensitive for detecting joint involvement. And here's a study where they looked at MRI detected osteitis, an independent predictor of RA development. They looked at 116 patients. They used the old 1987 ACR criteria after 1 year, and they found that RA was if they've used the Omerac bone edema score, they found that MR was to be an independent factor for the diagnosis of joint involvement with rheumatoid arthritis. What is the value of MRI-detected tenosynovitis evaluating patients with undifferentiated arthritis? Flexor tenosynovitis is diagnosed by MRI, had a strong predictor of those patients who would go on to have rheumatoid arthritis. These are older studies using the older definitions for rheumatoid arthritis, and then combine flexor tenosynovitis on MRI with a positive serum anti-CCP or positive RI factor was a very strong indicator that the patient has early rheumatoid arthritis. And then ultrasound is also used a lot, as you know, in trying to differentiate patients with undifferentiated arthritis and rheumatoid arthritis. MRI, erosive synovitis, and bone edema increase the probability of developing RA from undifferentiated arthritis. The absence of MRI synovitis significantly decreased the probability of these patients going on to develop a diagnosis of rheumatoid arthritis. Ultrasound in that setting really hasn't been well studied at this particular time. and they suggested further research was necessary. So here was a study. Here's actually looking at a number of studies that were published in the first part of this century, where they looked at whether or not positive erosions by MRI were predictive of progression in these patients. And if you notice here, if you look at MRI osteitis, all of the studies, except for where it was not evaluated, shows that MRI indication of osteitis was a predictor of patients going on to develop bone erosions at that site. The only one that wasn't here was this study from England by Brown et al., but in their study, they only used T1-weighted images. They had no stir or fat-suppressed images, so they couldn't detect MRI osteitis. So from all of these studies, it's clear that MRI-detected osteitis is a strong predictor of development of erosions and most likely is the pre-erosive stage in rheumatoid arthritis. Therefore, if we can detect MRI osteitis before the patient has actually X-ray determined erosive disease, and you treat it and you stop the inflammation, you can actually stop them from progression to destructive bone disease. And I think that's an important thing that needs to be recognized by MRI, is that we can pick up the precursor lesions at a stage when they're still reversible, and X-ray-based technologies and ultrasound cannot do that. There are studies back in the early 2010 that showed that if you actually use the new medicines to tightly control inflammation, you actually get better outcomes. And therefore, early treatment has been shown now by many studies to markedly improve patients' functions and decrease symptoms in patients with rheumatoid arthritis. So one of the problems that we had in the early days of looking at arthritis was the criteria. And that for many years, since 1987 up until this century, the American College of Rheumatology criteria for RA was the standard. And what we found is that standard will not diagnose rheumatoid arthritis until after you have irreversible bone destruction. So without irreversible bone destruction, you can never meet the old criteria for making the diagnosis. So the American College of Rheumatology and the European League Against Rheumatism came up in 2010 with a new criteria for making the diagnosis of rheumatoid arthritis. It involves 4 different areas. A physical examination, which determined the number of joints involved, serologic studies, primarily our rheumatology factor, but also ACPA, the duration of symptoms, and whether they're acute phase reactions are positive or negative. And if you add these up, and if the score was equal to or greater than 6, that then is considered a definitive diagnosis of rheumatoid arthritis. And these were published in 2010 in the Annuals of Rheumatoid Disease and the Arthritis and Rheumatism. So that's as far as I know, the current diagnosis. Now, there have been a lot of studies around that time and after that time looking at MRI and ultrasound to see if MRI and ultrasound were more sensitive at detecting joint involvement, since joint involvement is a major determinant of the score system. And it's the people who basically published the new criteria came up in 2011 and 2014 that MRI and ultrasound may be used to determine a more complete joint involvement after the patient has been found eligible for testing. So if they have a high clinical suspicion of rheumatoid arthritis, then you should go through the joint count and add up the score. And if you want to have maximum sensitivity, you can use MRI or ultrasound to help augment the joint involvement score and detect rheumatoid arthritis earlier. So after 2010, 2011, we actually had a criteria for making the diagnosis of rheumatoid arthritis early enough where we had the possibility of actually treating the disease and minimizing irreversible changes. So you need early diagnosis, and MRI can be helpful with that. So MRI plays a role in early diagnosis, detecting joint involvement, and also predicting future erosions. Now, as far as detecting and quantifying synovial inflammatory disease, there have been a number of papers looked at this. Ultrasound and MRI are significantly better than clinical examination and plain radiographs in detecting RA patients in clinical remission who have subclinical inflammation and risk for progressive structural damage. And we know in previous years, the patients who seem to be in clinical remission, but before we had good drugs for them, that they tended to have progressive disease and end up with poor prognoses down the line. And therefore, it's essential for optimal patient outcome that RA patients be staged and possibly monitored by ultrasound or MRI, even when they're in remission, and that if they are positive signs by ultrasound or MR, and MR is a much more sensitive of the two, of ongoing inflammatory disease, that may not be a remission, and they may be able, it's possible that they should stay on drugs, or if they are on drugs and they continue to have inflammatory disease, to bump up their regimen to a more aggressive treatment. And there are a number of studies that looked into this and suggested this as a possibility. We'll come back to this later. There are later studies after this which have tried to use MR and helping to determine drug treatment, and is, I think, finally determined that MR was not as effective as we thought it was going to be at trying to determine what patients should stay on drugs. There are some issues with that. It's somewhat controversial because most of the money that's used to do these studies are from the drug companies, and any studies where MR might be used to decrease the amount of drugs used would not be something that the drug companies would want to support. So there certainly is some bias in the published studies. People have also looked at high field versus low field MR and RA, and basically there's mostly agreement between the two. High field may be a little bit better for osteitis, but the bottom line, if you do correct imaging, there's not clear evidence that high field is better, though I think it's fair to say in this day and age, since a lot of people don't have experience with low field, most of the low field scanners are not state-of-the-art anymore, that in this day and age, high field imaging is overall better than low field imaging evaluating RA, though you could make an argument that if you had state-of-the-art low field scanners, you could have protocols that would allow you to be just as effective. But in practice, that's not the case. Here's a study where they looked at multiple fields, different fields back in 2014, and they really found no consistent, clear advantages of high field. But that's at a time when the high field scanners weren't as sophisticated as they are right now, and we don't really have a lot of state-of-the-art low field scanners available now. So the summary then is that early diagnosis leads to better outcomes, and many patients in clinical remission can continue to erode bone, so you have to be diligent in these particular patients if they're treated by methotrexate alone and are not on TNF-alpha inhibitors. So this was a systematic literature search that was published in around 2011, and that they basically found that at that time there was not sufficient data published to support the use of MRI in widespread use in diagnosis and prognosis of rheumatoid arthritis, and they said it remained undefined at that particular time. Here's another study where published in 2012, where they did a relatively rigorous study looking at patients and at the literature, and they really found that MRI measures of joint inflammation and damage to rheumatoid arthritis. You found that it was accurate at evaluating synovitis, osteitis, and bone erosions. And according to this particular paper, MRI actually met the OMERACT validation filter for truth, discrimination, and feasibility of using RA in randomized clinical trials. And right now, typically what occurs in clinical practice is that MRI is used for complex cases that don't fit the normal progression, and MRI is widely used now in all clinical trials, and the FDA actually uses MRI as a major criteria for effectiveness of drugs in clinical trials. So it's used widely for clinical trials, but less widely in clinical practice. And this was a study trying to look at cost efficacy of using MR. Again, the criteria were not the criteria that we thought were optimal, and this basically was a study showing that they couldn't prove cost efficacy for adding MR to the analysis. This is kind of odd because treatment for rheumatoid arthritis now is substantially more expensive than $8,000, and MRIs are actually significantly cheaper than $456. TNF-alpha inhibitor drugs can be $30,000 to $100,000 now. So I don't think that this was an appropriate cost-efficacy analysis. And this was a study where the European League Against Rheumatoid recommendations for the use of MR, and they basically found, looking through the literature in 2013, that MR was actually highly effective at improving the certainty of diagnosis, highly effective at looking at detecting inflammation. Ultrasound and MR is superior than other techniques for evaluating inflammation. X-ray can be used to detect damage, but again, the only damage that X-rays can show are irreversible bone destruction, and we really want to pick it up before that occurs to stop the disease before you have irreversible damage. And we've talked about most of these other things. Let's go on and talk a little bit about psoriatic arthritis. Typically, this diagnosis is made in people who have skin findings typical of psoriatic arthritis, or often even at the current time, or with a personal history or a family history of having a psoriatic skin disease. Also, psoriatic arthritis typically have pitting of the nails, which may be their only skin findings of psoriatic arthritis. You need a test for rheumatoid factor, though it is believed that a number of these patients will have both rheumatoid arthritis and psoriatic arthritis. And then something that's very characteristic of psoriatic arthritis is dactylitis, where you have one digit that becomes swollen and kind of universally inflamed of all the soft tissue elements of that digit. And it's really not seen in other diseases. The only other disease that can look like this is infection, which if you have an infected joint. And you can use both current or historical evidence of dactylitis. And then X-ray evidence. Psoriatic arthritis tends to be more peripheral. Rheumatoid arthritis tends to be more the metacarpophalangeal joints. And MR and ultrasound can be helpful. So this was where they looked at was there a diagnostic role for MRI in evaluating psoriatic arthritis? And what they found is patients with cutaneous psoriasis who have arthralgia and subclinical inflammatory lesions on MRI have a 60% chance of going on to have full-blown psoriatic arthritis versus only 13% without it. So MR is helpful at determining patients who have a clinical suspicion for psoriatic arthritis before they have full-blown syndrome, and these patients should be treated early on. So basically here we've talked about the historical perspective, looking primarily at rheumatoid arthritis, talked a little bit about DMARD therapy, pathophysiology, the roles of imaging in RA, and a little bit about the debate right now. I'd like to go on and talk about a few other areas right now. This is looking at uric acid disease and gout. This particular patient, here we can see a dual energy CT scan, shows areas of uric acid deposition within the joint space. Here we can see those at arthroscopy, a little bit of inflammatory change here. The dual energy CT can occasionally be helpful, though most studies have shown that the majority of the time dual energy CT is not that important in making the diagnosis, as the diagnosis can be made by standard clinical and biochemical techniques. So this patient has known diabetes, is on allopurinol, and here we can see a typical appearance with the marginal erosions in this patient, left and right. And then if you go to CT, you can see the areas of uric acid deposition in the joints if there's a clinical concern. And here we can see the typical marginal erosions of rheumatoid arthritis with these little spiculated edges, and then the uric acid deposition, and again, these typical spiculated edges, which are characteristic of gout. Okay, let's see. Robert, what do you think of this case?
Actually don't see any images at the moment.
Okay, so this is a 77-year-old male with left knee pain for 2 days, arthritis in the right knee for a couple of years, and a very high uric acid level. And it's a renal disease. So here's some images.
Okay. Looks like there's some calcifications, kind of anterior compartment, maybe associated with the patella.
Yeah, and so it's very common to have gout involve the quadriceps insertion on the patella, less common of the inferior pole of the patella. But here we can see the uric acid deposition in both of these areas, which correlate with the densities on the CT examination. And yeah. So, and as we know, uric acid crystals are high density on conventional CT. Dual energy can differentiate them from calcium, and so that can be helpful. I don't think we've actually talked about how the gout crystals produce inflammation, have we?
I don't think so.
Okay. You know, I'm going to have more of a lecture on that later, so I'm not going to do it now, but we'll go through and show that exactly how the gouty crystals actually produce inflammatory disease, because that's very well recognized that in a future lecture, which may be with the foot and ankle. So why don't we stop here, and our next lecture will be a week from Thursday. Okay? Any questions?
Sounds good.
Thank you.
Thank you.
See you
Thank
tomorrow.
you.
All right.